Speaker for this morning's session is Dr. David Kuhar. Dr. David Kuhar comes to us from across the street at the CDC, where he's a medical officer with the Division of Healthcare Quality Promotion. He'll be talking to us about infection control myths and lessons.
Well, thank you for having me here. Very quickly, I'm going to begin with discussing transmission-based infection control precaution, really just as a review for a basis of the rest of the talk. And then I'm actually going to get into 4 topics that I think are relevant for healthcare workers across the nation and address where I think there may be misperceptions or even some recent lessons to be learned. So first, transmission-based precautions. These consist of contact precautions, both direct and indirect, and those that address aerosol-based transmission, requiring droplet or airborne precautions. So direct contact transmission occurs when microorganisms are transferred from an infected person to another without a contaminated intermediate in between. And I think an example of this would probably be a provider becoming infected with HIV after, say, coming into contact with blood from an infected patient, or having that blood, let's say, having that blood come into direct contact with a cut in their skin. A Sharp's injury might be a good example. Indirect contact transmission involves transferring a pathogen through a contaminated intermediate, object or person. And so I think a fair example would be C. diff being transmitted between patients silently on the hands of a healthcare worker. There have been recent reports of outbreaks involving duodenoscopes, transmitting multi-drug resistant organisms. Another example of indirect contact transmission. And then droplet and airborne transmission of pathogens, or transmission address aerosol transmission, basically. And for healthcare settings, aerosols are really referring to particles ranging in size from a thousandth of a micron to 100 microns. Those that are less than 5 are small, typically remain suspended in the air for long periods of time, and can cause airborne transmission. We're talking about tuberculosis, measles, TB. Those that are larger than 5 microns, roughly, are heavier. They tend to travel a short distance. It's hard to assign an exact distance to it, but we're talking typically less than 6 feet, and they fall to the ground. And wearing something like a face mask to protect yourself from those sprays of droplets hitting your mucous membranes where a pathogen may be transmitted based on that contact explains droplet precaution. So, I think an important question to ask is, do transmission-based precautions indicate how infectious diseases are transmitted person to person? I think clearly that's the intent, right? Well, I think the answer is no, not necessarily. And I think for this audience, most probably realize this already. The approach to protecting yourself can really vary depending on patient care conditions. And a perfect example of this would be aerosol generating procedures. These can artificially create small particle aerosols that may enhance the transmission of infectious diseases typically transmitted by droplet or airborne precautions, or they could allow infectious diseases that are transmitted naturally through other routes, like contact, to be opportunistically transmitted by an aerosol. And this is a really important concept. I think Ebola, in particular, has drawn a lot of attention to this, with concerns that could you aerosolize it and cause transmission. Now, the SARS epidemic, I think, is really where aerosol-generating procedures were discussed quite a bit in the literature. And I think it was highlighted because workers who wore face masks for patient contact, some of them still developed SARS. Risk factor analyses tended to identify procedures such as intubation or cardiopulmonary resuscitation as risk factors for developing the disease. The thought was, and the theory was, these procedures generated small particle aerosols that could suspend in the air, float around the face mask, and were inhaled by healthcare workers. So seasonal influenza and recommendations for infection control, I think, are a great example to kind of demonstrate this point. We obviously recommend standard and droplet precautions. This prevents transmission of seasonal flu. However, for aerosol-generating procedures, we recommend wearing N95 respirators. So, a list of suggested procedures to control to consider aerosol generating for flu patients is listed here on this slide. One of the biggest challenges for aerosol generating procedures is they haven't been well defined in the scientific literature. We have very limited evidence to identify which ones generate aerosols and which of those aerosols actually pose risk to people who are in the vicinity. And this is unfortunate. However, I expect that in coming years, this is going to get a lot more attention, as this has been one of the bigger areas of focus. But ultimately, the message here, if you're going to be present for a procedure, let's take the influenza patient again as an example, consider the potential for aerosol generation. You can always err on the side of safety and wear a respirator to protect yourself. And keep in mind, there are many infectious diseases at this point for which additional precautions are recommended for specifically aerosol-generating procedures, and this is even discussed in guidelines for MERS as well as for Ebola. So let me move on to contact precautions. I'm going to touch on what I think remains an old but incredibly relevant question. Does being vigilant and active in preventing disease transmission by isolating patients in healthcare come at the cost of patient safety? So if you do a literature search, you're going to easily find 15 to 20, I think, lower quality, but studies that address the issue and show or discuss patient harm. And these typically identify 4 points. First, if you have patients in contact precautions, there are fewer healthcare worker contacts. We go into the room less than we usually do. And not every study has looked at this or reported it, but there's a good number. The second, I think, is very important, that changes in systems of care might increase non-infectious adverse events. So, delays in patient transfers to, say, a nursing home or to rehab because they're on contact precaution leaves them kind of stuck in the same place. And this, in a way, can serve as a vehicle for other complications to happen. For example, more patient falls have been demonstrated. Pressure ulcers, electrolyte disturbance in patients just because they're on contact precaution. And I think the last two here are fairly straightforward and that many of us feel we have either heard about it or seen it happen. Depression and anxiety among isolated patients and decreased patient satisfaction, all of which make, I think, very good sense. But what I want to present here is a point in contrast to what I think seems a pretty overwhelming literature on the subject of harm with patient isolation. So the BUG study was designed to actually assess if universal glove and gowning would decrease acquisition of MRSA or VRE when compared with usual care, and it was done in ICU setting. So their primary outcome was actually acquisition of drug-resistant bacteria. However, it's their secondary outcomes that I want to talk about here and that I think are most relevant. And they looked at the frequency of healthcare worker visits into rooms, hand hygiene compliance, and adverse events among these patients. So, the investigators showed decreased healthcare worker room entry for those that were ungloved, for universal glove and gowning, and increased hand hygiene. I think this makes good sense and is what we would expect to see. But importantly, they showed no statistically significant effect on the rate of adverse events. And I think this is pretty important. What does this mean? Now, I think it doesn't mean that contact precautions are harmful. That's not the message here. Rather, they can be enacted without increasing adverse events. And they show that here in a randomized trial that was fairly well designed. Particularly, I think in an ICU, it's probably achievable. There's better patient visibility. There's more providers per patient in a unit. But I think the important thing is don't be deterred from placing someone in contact precautions if you think it might be necessary. Harm is not guaranteed. I could say, in a point of contrast, I know with the Ebola outbreak this year, there are many people who've been placed in contact precaution with suspicion of Ebola. Most of these people did not have it. For example, they had malaria. There is risk for delaying care, and though I have no data to support it, I wouldn't be surprised. This delayed people's treatment and may have led to some adverse events. Measles. I couldn't get by without discussing measles. We've had an increase in the number of cases in the US, as well as and several states have seen it, including this one. Measles, as you know, is an acute febrile rash illness, and it's transmitted by airborne spread. Having presumptive evidence of immunity to measles is the most important thing that healthcare workers can do, I think, to protect themselves. And criteria for having evidence of immunity includes written documentation of receipt of the vaccine, or the vaccine series, I should say, having laboratory evidence of disease or that you've been vaccinated, having positive antibody titers, and birth before 1957. It's important, I should add that it's recommended that those who do not have presumptive evidence of immunity to measles not care for measles patients. Have someone who does have it provide that care. So I'm going to pose a question where I think there is a lot of confusion over what to do. Do healthcare workers who have presumptive evidence of immunity to measles need to wear an N95 respirator or better when caring for those patients? In previous guidelines, I could say isolation precautions from CDC in 2007, this issue is partly addressed, and CDC stayed silent on it, saying we have no recommendation. There's no evidence to tell us whether or not you actually need to do this, and said there's no recommendation. Many people took this to mean you don't need to. And I think that that might have been a little unfortunate. There is actually some relevant data. So this very busy table shows measles transmission in US healthcare facilities between 2001 and 13. If you look at the bottom line, you'll see that there were 57 measles cases reported in the time frame, and 17 healthcare providers who were infected while at work. One of those healthcare providers actually transmitted to another patient, and I'll tell you that their vaccine status and evidence of immunity was unknown. We don't know. But the important thing I want to emphasize is that last column. It shows immunity status of the infected healthcare providers. And several of them, 7 or 8, had presumptive evidence of immunity and developed measles. This is really important. So it's small numbers. Still, this has actually recently been readdressed. The Advisory Committee on Immunization Practices in Immunization of Healthcare Personnel 2011 updated the no recommendation for respirator to basically saying that regardless of your presumptive evidence of immunity, all healthcare workers who enter that room should wear an N95 respirator. As a caveat, remember, measles is the most contagious vaccine-preventable infectious disease. Probably one of the most contagious infectious diseases out there. Ebola, one case might often produce 2 more for transmissions. Measles, we're talking one person can generate 20 cases. It's incredibly impressive. For healthcare workers who are not immune, and do not have evidence of immunity, who wear an N95 and go into that room, it's very likely to be recommended that they be removed from patient care afterwards to ensure containment of this disease so we don't, risk endemicity. And my last point, this year has brought, I think, personal protective equipment into the spotlight, and the emphasis upon it has been incredible. I think news media, as well as many scientists have really emphasized having the right personal protective equipment, caring for patients. And so I think I want to pose the question, because I think how people think about personal protective equipment is critical in sort of determining its efficacy. So does having the right personal protective equipment mean you are safe? And I think what I want to emphasize is that no, it doesn't. But let me explain why. Don't panic. Let me explain why. There are a few studies out there like this one. And here, in this one I'm showing you, investigators look at personal protective equipment and the hands of healthcare personnel after exiting patient rooms And these are patients who were known to harbor drug-resistant organisms, and they had their personal protective equipment swabbed and cultured to look to see if they picked up resistant bugs, as well as their hands after doffing, but before washing. So they wanted to see, did they pick up drug-resistant bugs? And if you look at the results, you'll find roughly a third had their personal protective equipment contaminated coming out. Not surprising, right? If you're touching a patient, that's what's going to happen. And I would say that I've a lower number than I would expect for those showing contamination of their hands after removing personal protective equipment. And this is before washing. These are people who knew they were going to be surveyed coming out, so they were paying extra special attention to it. The bottom line is we're excellent at contaminating ourselves when doffing. We're very good at it. I've done it. I mean, if any of you have tried using Glow Germ or something to indicate how, if you've contaminated yourselves, you'll find you do it. Most people probably do it, and it takes practice to learn how to remove that equipment without doing it. In Africa and in Dallas, we had healthcare workers who developed Ebola despite wearing fully covering personal protective equipment. This is really important. Fully covering, right? Having the right personal protective equipment is obviously critical, but unless you can remove it without contaminating yourself, it might not do you a bit of good. There's a very, very old recommendation. I think it goes back as far as the 70s, that healthcare workers be educated and trained in preventing transmission of infectious agents, that they be shown how to remove personal protective equipment without contaminating themselves, and that employers should document competency and proficiency in doing so for routine stuff and for routine pathogens. And I suspect this is largely not done throughout the country. I like to think that what's happened with Ebola will send the message to all of us. We need to do better. C. diff, MRSA, these are transmitted the same way. We have, 750,000 healthcare-associated infections every year, 75,000 patient-related deaths. I think doing this better has the potential to save tens of thousands. And anyway, I'm going to stop there. Take any questions.